This patient's chances of going through surgery without incident are greater than ever today. Her bill also will be greater than ever. Almost $1,800 for the 4 days, including the surgeon's fee. Most of the bill will be covered by health insurance. But the health care system under which the patient is treated is made possible by taxpayers. Tax money has made health care the third largest industry in the nation, the first largest in New York State. It is big business, but unlike big business, it is disorganized, wasteful, inefficient, and burdened by enough paperwork to bury an army. Why should you know this? Because 10 cents of every dollar you spend goes for health care. Because, sick or not, you work 5 weeks a year at your job just for health care. And the records show that you're not getting any healthier for it. Janice Schachter is packing a suitcase to go to a hospital for surgery, the removal of cysts from the base of her spine. Even before she is admitted, the paperwork begins. A large folder sent to her by the hospital, a voluntary institution in New York City, contains insurance and consent forms that are filled out and mailed back. In this way, Janice may pass through admitting according to computer expectations.
Can I help you? Yeah, I'm Janice Schachter. I'm being admitted. Okay, who's your doctor? Kessler.
Through Janice Schachter's hospital experience, some of the complexities and contradictions of healthcare become evident. Here, Janice is introduced to an environment in which there is written documentation for everything. Her folder has already begun to inflate, and before she leaves for home, there will be almost 100 different papers in her file.
This form states that the hospital isn't responsible for any valuables, and it gives consent for treatment ordered by Dr. Kessler. Not for surgery, just for medical treatment like blood tests, x-rays, things like that. Sign there.
As she moves through the admitting process, computers print out information about her, with copies distributed to departments that will be involved with her case. There are countless insurance forms and papers for some of the 164 federal, state, and local agencies that regulate hospitals. As a result, hospitals are forced to maintain large office staffs. Where administrative offices once were contained in 2 or 3 rooms on the main floor of any hospital, administration personnel may now fill 2 floors. This is part of the health system bureaucracy which critics call staggering, irrational, and full of monumental inequities. While government regulations are aimed at cutting costs, the system actually encourages duplication, costly, and unnecessary practices.
A malpractice case can hinge on whether a doctor took a cardiogram or not, preoperatively. If there's no indication to take a cardiogram preoperatively, and he has a second case coming up, he will order the cardiogram anyway, because on the last case it was important. And doctors are being educated to get as many tests on the chart as they can to protect themselves. The doctor's patient runs a little fever 2 days after an operation. Where formerly he would treat this himself, today he calls a consultant. This again increases medical costs.
When you're at home, do you eat a regular diet?
Yes, I do.
Okay. And you wear glasses and contact lenses. Your occupation?
A student.
Okay. Have you ever been in a hospital before?
No, I haven't.
And you've never had any surgery?
Nope.
No, you haven't. Okay, that's very good.
The patient's chart today, 70% of it represents forms that we did not have 4 or 5 years ago, and hopefully it will not continue to increase, because otherwise the entire process will become meaningless as regards the patient. lot of noise and kind of a scary place to be in, but it's just like it is on TV.
I expected it much differently. I expected it to be much more, not as brightly lit, much more crowded.
Neither paperwork nor bureaucracy intrudes on this genuinely human moment between doctor and patient before the operation.
And you'll have an intravenous started, and then you'll go to sleep.
Fine. That's all right with me.
You won't be very uncomfortable.
How long do you think I'll be in the hospital?
About 3 days. We have utilization committees and utilization reviews that did not exist 5 years ago. There is a staff of approximately 7 people downstairs today who are involved only in deciding when the government thinks a patient should go home or whether there is an overstay or overutilization of the facilities of the hospital. This group of people must have a financial base of at least $150,000 a year in salaries, and I'm not quite sure how much they actually save the hospital in terms of hospital stay days or what they actually contribute to the eventual care of the patient.
The Office of Utilization Review is relatively new to hospital procedure. The criteria for utilization review, which has been dubbed the cookbook by doctors, specifies how long a patient may stay in the hospital. Age, illness, and the history of the patient determine length of stay.
Well, certainly from all the information at hand, it is apparent that we cannot justify the admission of this patient. And I think that what we should do is to proceed in our usual fashion. If you will look up the doctor's office telephone number while I'm here, I'll be happy to speak with him and explain the reasons for our decision and give him the opportunity to explain any extenuating circumstances that is not apparent from his note.
Do you have a savings account or a checking account?
No, no longer.
Just as utilization review was created by the insurance community, though its criteria set by doctors, the financial counselor also owes his existence to health insurance.
No.
The counselor came into being as hospitals looked to insurance companies rather than individual patients for reimbursement.
No.
Do you maintain a safety deposit box?
No.
In other years, a patient without money or insurance had to go to a city-owned hospital. With the advent of Medicare and Medicaid, patients may go to almost any hospital. But insurance doesn't pay for them all the way, according to hospital accounting, which some say has been forced into inflationary practices by a strange reimbursement system.
When Medicaid and Blue Cross rates are below our cost, we are required to seek donations, and we're also required to charge other patients higher rates than would normally be charged in order to subsidize lower than cost Medicaid and Blue Cross rates.
In a nutshell, Mr. Reed, what is bringing about the spiraling costs of health care?
We have a variety of problems in trying to control the cost of hospital care in particular. Certainly the rapid rate of technological advancement is a serious hurdle for us to keep up with. Since the space age, while we have found that things like CAT scanners that cost $500,000 to $800,000 are available for enhancement of patient care. And it's our objective to try in as much as possible to bring the latest technology to the bedside, and this is very expensive.
The cost of the CT examination varies from institution to institution. It runs between $175 to maybe $300, depending upon the institution. CT scan takes a cross-sectional view of a body part, the head, chest, or abdomen, anywhere from a 2 millimeter to a 10 millimeter section of the body, and we actually see the tissue of the body as never before. This equipment has decreased a lot of other procedures that have a morbidity and mortality associated with them. Needles were placed in patients' neck or spine, and contrast agents or air were injected. Now with this study, the patient just lies on the x-ray table and the x-rays are passed through the body part. So we have no morbidity and no mortality associated with this procedure at all. The CT scanner has been called the greatest impact on medical care since the original application of X-rays to medicine.
We pay for the CAT scan if the facility has been approved by the state health department for having that available. We will not pay if a facility proceeds without the certificate of need from the state, and so we are reinforcing the state regulation in this regard.
To get the certificate of need, how much time and how much paperwork is involved?
3 months.
3 months? Can a patient wait 3 months, though, if he needs a body scan or a head scan?
In our area, let me assure you that there are plenty of CAT scanners available.
But still, this doesn't take care of the patient who needs to say at any one hospital the patient might be in.
There are regionalized approaches to this and cooperative arrangements. Not every hospital needs a CAT scanner, and they have regionalized this to make it readily available. And we feel that the patients have this accessibility assured.
A charge of body snatching by ambulances has been bandied about between voluntary and city hospitals. The voluntaries accuse the city of using its 9/11 ambulance system to poach on districts served by voluntary hospitals. This would indicate that all hospitals are hungry for patients. But the contradiction here is that while state and federal regulations are aimed at keeping people out of hospitals, hospitals are looking for people to pull in. Patients mean money in the form of reimbursements from Medicare, Medicaid, or Blue Cross. Money hospitals need to survive the almost bizarre economics of health care.
What are you thinking? She's going to Bellevue. All right.
It is true that in the past, in a certain modest number of instances, there were patients who were taken by ambulances to institutions not of their choice, by both voluntaries and municipals. And I have the data and the evidence, and it is something that occurred on both sides, and relates to the fact that we have a reimbursement system that encourages all hospitals to have as high a census as possible. And at a point in time when there are excess beds, there's been an effort by hospital administrators, all hospital administrators, to try to fill their hospitals. That is one of the causes of high health care.
This city has 5,000 excess beds, and we're trying desperately, many people are working on this, to try to cut down the number of hospitals, the number of beds, combining services, and to take a very small example. If you have a large X-ray machine that's been purchased for $500,000, cobalt machine, let's say, and it develops that it's only used half-time, and a hospital down the street has one that's only used half-time, they're both paying for the total cost of that machine, and to keep it probably geared up and staffed up for full utilization, when if they both combined their patients in one institution, they'd save the cost of one of the unit in one particular hospital. That's the best example I can give you.
Who are the culprits in this whole healthcare situation?
We're all the culprits. The patient's the culprit that wants hospitalization when hospitalization isn't necessary for a procedure that can be done on an ambulatory basis. The hospitals want to stay in business. They don't want to close their doors. The doctor's culprit because in many instances it's more convenient for him to have a whole group of patients in the hospital than see him at his office.
The average doctor puts patients in the hospital to protect himself primarily against the charges of malpractice.
I grew up in an era where patients received medical care. They went to their physicians and they weren't turned away by doctors. And it's only been in the past few years that we've had the development of all these third-party type insurance plans, which have although they've allowed patients to have an easier time of paying their bills, unfortunately, in many cases, it's allowed doctors to choose the type of patient that he's going to want to treat. And I think that in many cases, you can find physicians who, for instance, won't treat a Medicaid reimbursed patient because, say, the fee will not be high enough to justify what he feels will be the amount of time he will spend with that patient. We didn't have this before. Before many of these programs, I think we had physicians who were just dedicated to treating patients and anyone who walked into their offices. In response to this, I think we've seen the growth of many new delivery systems. In addition to the private physician delivering health care, we have seen the growth of the emergency room as becoming a primary care center for treatment of patients. We've seen many clinics develop that didn't exist before. Health maintenance organizations are developing. And all of these in response to what is considered to be the patient who doesn't have the type of money needed to get good medical care. And from my experience, I think that each type of system of delivery that we have offers up-to-date medical care. And generally, these doctors are well-trained.
Dr. Orship, what are you going to charge for openers?
For openers? It depends. A member of my family can probably come for nothing.
Certainly new patterns of health care are developing, but in the view of many, an effective system cannot come about until a national policy for health care is established, sweeping out questionable aspects of the system. At clinics, for example, if a Medicaid patient seeks treatment, the government reimburses the hospital $55. There is a sliding fee scale for patients who pay out of pocket, and if you earn $25,000, your bill would be only $40. Why soak the government? Why the tendency to get as much as possible from the government?
Consumers feel as if it's a free lunch. They don't realize that the average citizen in this state works 5 weeks a year just to meet the health care bill. And the consumer does not appreciate that every product he buys has a health care cost component in it.
How much does medical care cost you a year?
Not much. I don't need it, I'm sorry. Luckily. Probably about 500.
Well, I belong to a union and they have the coverage, full coverage. So that way, that's like taken out of our salary. And it covers everything for the whole family.
So how much does it cost you about?
Gee, really, I couldn't say offhand.
I don't really know, but it's not too much. I'm pretty well covered by insurance in any event, so.
I really don't know. It's something I don't even like to face.
It doesn't cost me too much at all because most of my health care is paid for by the company that I work for.
It doesn't cost me anything. Luckily, I've been able to take care of myself and get health care, and it doesn't cost me a cent.
The consumer doesn't realize that his real property tax rate is determined to a large extent to health care costs. And in upstate New York and many county budgets, Medicaid now exceeds 50% of the county budget. I think it's a lack of cost consciousness on the part of physicians who are trained to do the most and the best for a patient. Unfortunately, in today's legal climate, they have to practice defensive medicine, and people get over-tested and over-treated in many instances.
And over-operated?
And in some instances, over-operated. I think it's also part of government's fault. The government, for years, had a federal program to finance hospitals with loans. State government also had a program encouraging great expansion in our healthcare system. Government, in 1966, with the introduction of Medicaid and Medicare, adopted a very inflationary reimbursement system with essentially a pass-through of costs. The other is that there's an American myth that you can improve the public's health by ever-increasing expenditures for hospitals and doctors. And we've lost sight of the fact that historically and true today, that most advances in health will come about, number one, by what people can do for themselves. We drink too much, we eat too much, we don't exercise enough, we engage in crimes of violence, homicide, suicide, drug addiction, alcoholism, will never be cured by the creation of more hospitals. The other is that we've been very negligent in the control of our common environment. It's been estimated, if one includes skin cancer, that about 80% of cancers are environmentally related.
Hi, Janet.
Good morning.
How are you?
Okay, I'm
Good.
good.
Okay, you saw Dr. Kessler,
Yeah.
and he gave you your discharge instructions.
Right, can.
And I gave you your dressings, and you bathed it on. If you need any help, you know how to change it. Your mother, I also told how to change it.
All right, got everything.
Okay, so do you have any questions about what you should be doing at home?
Not really. Is there anything I have to pay or sign or pay
No,
for?
I have a credit clearance for you right here.
Okay.
Okay, and I'll send you a bill for your TV.
3 days after her operation, Janice Schachter prepares to leave the hospital, but she will not have to stop at the credit office on the way out to pay her bill. That's the way it used to be. It used to be, too, that the patient knew the amount of the bill before leaving the hospital. Now, the bill is sent directly to the patient's insurance carrier, so the patient leaves the hospital without paying a cent.
Janice's bill for the 4-day stay is actually a reimbursement to the hospital of about $240 per day, although our hospital cost is about $282 per day. So that for the 4 days that Janice was here, the Blue Cross reimbursement to us will be $962. Our cost for her stay for the 4 days is approximately $1,128.
Having shared the hospital experience with Janice Schachter, it's easy to see how people get the erroneous idea that health care doesn't cost them very much. Just as medical dramas and movies and on TV never deal with the realities of paying a hospital bill, Janice goes home without the vaguest idea as to the cost of her 4-day stay. Is this premeditated insulation? On the other side of the coin, how is it possible for a hospital to stay in business if it loses as much as $40 a day per patient, as we are told in Janice's case? Fundraising, donations, further taxation? Is it also a matter of some doctors and hospitals doing more than necessary for patients because the more they provide, the more income they receive from insurance? The culprit, then? No one person or thing, but a healthcare system that cries for reform, an aware public, and leadership that knows what it wants. This is Marie Torre.